Hi everyone, I'm Tanisha and today I will be presenting on hypovolemic shock. Hypovolemic shock is a significant decline in the blood volume within the intravascular compartment. Hypovolemic shock occurs when there is an acute loss of 15 to 20% of circulating blood volume, resulting in decreased tissue perfusion. This can be from hemorrhagic causes such as loss of blood in trauma or GI bleed, or non-hemorrhagic causes as in loss of plasma from burns, loss of extracellular fluid from dehydration, from vomiting, excessive sweating, or from third spacing, loss of fluid from the intravascular compartment into the interstitial space. There are 4 classes of hypovolemic shock. There's the initial, compensatory, progressive, and irreversible stages. In the initial stage, there is a loss of 15% of blood volume, resulting in a reduction in cardiac output, causing a decrease in tissue perfusion. Lactic acid builds up as oxygen levels diminish, and there is a switch from aerobic to anaerobic metabolism within the cells. In the compensatory stage, there is a loss of 15 to 30% of blood volume. Compensatory mechanisms involves the sympathetic nervous system releasing epinephrine and norepinephrine, causing vasoconstrictions of the blood vessels and increased contractility of the heart, thus increasing cardiac output and blood pressure. There is shunting of blood away from non-vital organs to vital organs and movement of fluid from the interstitial space to the intravascular space, all in an attempt to further increase venous return to the heart. The renin-angiotensin-aldosterone system is activated when the kidney sends a decrease in blood pressure. This results in angiotensin II causing vasoconstriction in the blood vessels, thus increasing vascular resistance. Aldosterone is released from the adrenal cortex, and pituitary glands release antidiuretic hormones, stimulating the kidneys to retain sodium and water. There is also constriction of the hepatic vasculature, mobilizing stored blood in the liver to further increase intravascular volume and blood pressure. In this stage, you'll see an increased heart rate, increased respiration in your patients, a normal blood pressure or near normal blood pressure, decreased urine output, decreased peripheral pulses, mild anxiety may also be present. As compensatory mechanisms begin to fail, we are entering the progressive or the non-compensatory phase of hypovolemic shock, where there is a loss of 30 to 40% of the blood volume. In this stage, cardiac output and blood pressure continues to diminish, and there is worsening tissue hypoxia and increasing lactic acidosis. There's development of multiple organ dysfunction syndrome. There's also presentations of altered levels of consciousness, as we see a decrease in the cerebral perfusion. There is respiratory distress from decreased gaseous or diminished gaseous exchange and decreased lung compliance. At this point, the patient may need to be intubated and mechanically ventilated to maintain respirations. There's development, or there may be development of arrhythmias due to ischemic cardiac tissues. Decreased kidney perfusion affects the nephrons, resulting in acute tubular necrosis. There is oliguria and anuria, elevated BUN and creatinine, and metabolic acidosis. In the liver, there is dysfunction resulting in elevated levels of ammonia and bilirubin. Elevated glucose levels are due to the body's continued stress response and inability to regulate its glucose. There's also development, or there may also be development of disseminated intravascular coagulation, DIC, which may result in massive bleeds. At this stage, if treatment is delayed or there is progression into the irreversible stage. In the irreversible stage, there is blood loss of greater than 40% of the blood volume. There's progression of MODS, multiple organ dysfunction syndrome. There is end organ damage, respiratory and cardiac failure, and interventions at this point are going to be futile as death is imminent. Okay, some clinical manifestations: tachycardia, tachypnea, hypotension, cold, clammy skin, pallor, altered levels of consciousness, decreased urine output, elevated BUN, creatinine, metabolic acidosis, weakness, absent peripheral pulses. Diagnostic tests include CBCs with differentials, basic chemistries, arterial blood gases, coagulation studies, D-dimer serum levels, EKG, echocardiogram, imaging ultrasounds, CT scans, chest x-rays, in an attempt to find the source of injury. Treatments include fluid resuscitation with crystalloids, that's your normal saline urolactated ringers, blood transfusions with whole blood, packed red blood cells, platelets, FFPs, sodium bicarbonate infusion or administration, albumin infusion. Patient may require surgical interventions to treat underlying causes, administration of pressors, phenylephrine, vasopressin, levophed, epinephrine to maintain blood pressures, oxygenation, endotracheal intubation, and mechanical ventilation. Case study. Miss Casey is a 22-year-old co-ed university student. She was rushed to the emergency room 35 minutes after sustaining multiple stab wounds to the chest and abdomen. Her vital signs were heart rate 128, blood pressure 80/55, respiration 37 and labored. She had basilar atelectasis. Pupils were equal, round, and reactive to light and accommodation. Her levels of consciousness was reported as awake, slightly confused, and complaining of severe chest pain and abdominal pain. Pedal pulses were absent, radial pulses were weak, herative pulses were palpable. She was started on intravenous lactated ringers at a rate of 150 mils per hour. Case question number 1. With one word, identify the type of hypovolemic shock in this patient, and that would be hemorrhagic shock caused by trauma. Her clinical manifestations are tachycardia, tachypnea, shortness of breath, palpitations, pain, pallor, poor skin turgor, absent peripheral pulses, thready brachial pulses, capillary refill time greater than 7 to 8 seconds, cool clammy skin, evidence of significant blood loss. So based on case question number 2, based on Miss Casey's clinical manifestations, approximately how much of her total blood volume has been lost? So based on our clinical manifestations, Miss Casey seems to be in the progressive stage, and that would have that means she would have lost 30 to 40% of her blood volume. Case question number 8. Does the patient have a clotting problem? Alright, so her PTT and platelets are within normal limits, suggesting that her intrinsic and extrinsic coagulation pathways are still functioning appropriately, so there is no immediate clotting issues. Case question number 9. Explain the pathophysiology of the abnormal serum glucose concentration. Now, the stress response is activated, releasing cortisol and glucagon, promoting gluconeogenesis and glycogenolysis, increasing the blood glucose levels during stressful events or trauma. Case question number 10. Based on clinical signs after surgery, in which class of hypovolemic shock can the patient be categorized at this time? So the patient was taken to the operating room for surgical correction of lacerations to the right lung, liver, and pancreas. There she received an additional 6 units of type B positive blood. Surgery was successful and the patient was admitted to the ICU for recovery with the following vital signs: heart rate of 104, blood pressure 106/70, respiration 21, urine output 29 mL per hour. Repeat, BUN and creatinine revealed that these renal function parameters had returned to near normal values, and that's 23 and 1.4 respectively. Alright, now Miss MK's findings post-interventions denotes a class 2 or compensatory stage, characterized by gradual stabilization of her hemodynamic status and near normal lab results. Current research. Synthequin citrate. Now, this is a first-class resuscitative agent in the treatment of hypovolemic shock. It acts on the alpha-2b adrenergic receptors, inciting vasoconstriction, and alpha-2a adrenergic receptors, lowering the heart rate to improve cardiac filling. It also improves blood pressure, decrease blood lactic levels, and enhance base deficit. It facilitates less use of vasopressors and is valuable in improving multiple organ dysfunction syndrome scores and acute respiratory distress syndrome. Synthequin was safe and well tolerated with no drug-related adverse events. At this point, it is currently being used in India in the treatment of hypovolemic shock, and there are clinical trials ongoing for FDA approval for use in the United States. And these are my references. Thank you for listening.